Welcome everybody. Just wait for a few more people to jump on. Okay, I think we'll get started. So welcome to the Australian Primary Health Nurses Association webinar in Infection Prevention and Control in Wound Care with our guest speaker and subject matter expert, Cheryl Frank. My name is Lisa Sinkins and I will be your facilitator today. Also on our panel is Sarah Drew, who is the Nurse Programs Manager for the IPC Helpline. Today's webinar will be recorded and there'll be a link emailed to you later. We'll also have a Q&A at the end of this session. Any questions that we cannot answer, we will send to you in an email. So I'd just like to start by acknowledging the traditional owners of country throughout Australia and their continuing connection to land, sea and community. We pay our respects to them, their cultures, and to the elders past, present, and emerging. Okay, so today's webinar focuses on infection prevention and control in wound care. So we're not looking at the recommendations on dressings. If you've got any questions, pop them into the Q&A and you can upvote them as well. So the Infection Prevention Helpline is in association with Murray PHN. Our service is designed for all clinical and non-clinical staff who work in general practice, community pharmacists, and Aboriginal controlled health organisations, and is supported by our subject matter experts. If you have any questions around infection prevention and control, we encourage you to call us or go over to our webpage and fill in a web form with your questions. So it's not all about COVID. So today's obviously wounds. If you've got any questions, just contact us free and ask us all your IPC questions. Okay, so our guest speaker today is Cheryl Frank. Cheryl joined the Gold Coast Health District in 1996 as a clinical nurse consultant wound management. So she co-founded the Wound Busters Pilot Chronic Wound Clinic and is a director of Wound Busters. So today's learning outcomes, we will look at using evidence-based recommendations in infection prevention and control and implementing effectively into practice, applying safe practices to reduce any wound infection, and using the importance of using current educational resources. Okay, so over to you, Cheryl.
Good morning. Thank you everyone for attending today. It's wonderful to be collaborating with APNA once again. Now this topic is a very important topic because it's so much easier to prevent infection than to manage it. Now these are the 3 pillars that are recommended in the wound infection in clinical practice, part of the International Wound Infection Guidelines. I have a number of resources behind me that I'm unashamedly advertising. So when we're looking at this presentation, I'm going to be talking about section 3 first, because creating a good environment and a safe environment for our patients is probably the first pillar that we look at before we take on wound management. So I will let you read through those later, and then we do the patient care, and then they enter in the same route but on the other side, so it's right to left, so that we're always mindful of what we do. Before we go to the clean area, we wash our hands. Nothing that is contaminated will actually go to the clean area. We need to actually be mindful, and this was all for the photo. So the scissors are stored in a plastic container with a lid over the top, and we ensure that everyone that goes there has actually washed their hands. Next slide, thank you. And this is really important when we're talking about the new Wounds Australia Aseptic Technique Guidelines that I'll be discussing later. Before we even get to into the clinic area, we should have a waiting room where patients in wheelchairs, the majority of patients that we look after in wound clinics are over 65 with multiple comorbidities. So a comfortable area for them to sit, that there's space in between, that they're able to encourage one another with the treatments that we apply, and also form some sort of social group, because we know and we found out with our clinic that a lot of patients, because of wounds, are living in an antisocial fashion. They're aware that the wounds smell. They're aware that there's exudate. So coming into a group where other people share those same commonalities has created quite a lot of comfort for the patients that have been ordinarily left isolated. When you look at the clinical environment, you've got to look at your curtains. Are these proper curtains? And no, we needed to get antimicrobial curtains for our clinic. Do we need to actually apply drapery? And we found that when we remove a lot of the dressings, there's a lot of aerosolization in the air. So what we do is dampen down the dressings before we remove them, which is shown to actually reduce the aerosolization of contaminants and skin cells floating around the room. So we got rid of the drapery that we were using and just are on the beds with a paper drape, and we wash in between. And it's always really important that you're aware of how your antimicrobial cleaners work when you actually have fluid spillage in the clinic environment. Next slide, thank you. When we're looking at the patient's space, we want to know that there's room for the patient to enter the bed. There's room for the wheelchair to transport the patient in, to repopulate the bed. We need to be aware that the curtains need to be antimicrobial, that the trolley in particular is really important and is kept empty, so that in between each patient we're able to wash it all down. Trolleys are not to be used as storage spaces, so that drawer is completely empty. Each patient brings with them their own dressing products, and there is enough space for the clinicians around the bed to actually do the practices that they require. So when do you need to change your curtains if you don't have antimicrobial curtains? When do you need to clean your gloves? When do you need to empty the drawers? As I said, they all need to be empty. The gloves are only taken out and we change them as per the aseptic technique guidelines developed by Wounds Australia, which is the blue booklet next to the green International Wound Infection Guideline. Next slide, thank you. So when we're looking at the clean space that we've created for wound management, we need to have space for debridement and for biopsy. We need to have space in order to contain the risk. So looking at risk mitigation of aerosolization. We need to actually be aware of the dangers to the patients and to the clinicians in the area if we are performing initiatives that need to be, we need to mitigate the risk of. Next slide, thank you. We need to have space in order to actually educate the patient's carers to conduct the care of the dressings when they go home. In general practice, we've got to ensure that we apply the dressings appropriately, but that we also include a care plan for the carer, so that anything that should go wrong, the carer and the patient are able to problem solve quite efficiently. So we need space in order to do that, to conduct those measures. We need to have space so that when we are doing case conferencing of these complicated patients, and we've got a number of clinicians around the bed, that we're not breaching infection control guidelines in order to conduct our information exchange and clinical handover. So we need to be mindful that in these days of clinical practice with COVID, you've got to actually ensure that you've got 1.5 metres in between you. You're wearing your PPE as required, particularly masks and goggles for your eyes, and plastic gowns if necessary. So we need to be mindful of the space in which we work, and for every room, we need to know the meterage of the room and how many patients and carers we're going to allow into that room, because we may need to conduct the education in a separate room if there are patients involved. Next slide, thank you. Now, when we're looking at the host response of our patients, it's really important that we familiarise ourselves with the patient's care plans that we've already conducted. We need to look at the information that we already know about the patients before we go to the wound. So we need to know that if the patients have any form of immunocompromisation, we need to think, okay, these patients need to have antimicrobials to clean their wounds, to protect them from getting infected, because their bodies are unable to actually clean their skin, clean their wounds themselves because of the reduced natural immunity that they have. So a patient with diabetes, for example, or a patient with neutropenia will need to be managed in a different way to a patient that's 45, fit, has good blood flow, and has no forms of comorbidities that would lead to the risk of infections. We need to work with our doctors and discuss with clinical handover of each patient what is going on with the patient, what products we're using and why. What sort of risk mitigation do we need to do? Do we need to have the patients with no risk of infection come in early, the neutropenic patients come in early, and then the heavily infected and contaminated wounds at the end of the day? Or are you going to look at each patient being immunocompromised and at risk of being heavily contaminated? And that way you treat all of the patients the same. In our clinic, we look at the care planning, we look at the patients individually, and we try to ensure that the immunocompromised patients are in early and the contaminated wounds are done at the end of the day. It's really important to look at systemic symptoms as well. Know that your etiologies can actually mask the types of symptoms that patients will display. For example, diabetic patients that you know may not have the same signs and symptoms of infection that a normal healthy host response will have. So we need to be mindful of all of these things before we even enter into a care plan for the patients with a wound. Next slide, please. We need to, with every care plan and every time we assess our patients, we need to look at their feet. We need to take their shoes off and their socks off. In new evidence, we know that changes to the lower leg are already commencing in the lower leg before the patients are diagnosed with diabetes because of the metabolic changes that occur. And indeed, this is a non-diabetic patient with claw toes, dropped metatarsal heads, and you've got macerated callus on the metatarsal head. So this is something that we need to formally discuss with our GP and think, you know, what measures are we going to do in order to treat this patient holistically? We look at the skin and we look at the changes in the venous flaring that you can see in the malleolar region. So this will change altogether the signs and symptoms of infection, because we know with venous disease, for example, a common symptom of venous disease is high exudate. So if we're looking at infected wounds having high malodorous exudate, that can be a normal sign and symptom of a diabetic foot, which will be changed if they've also got a comorbidity of diabetes. We need to look at whether our patients have any form of sensation. We need to know that they can tell us if they're sensing pain. A lot of the time with diabetes, they're insensate and they can't tell us that they've got pain that's increasing associated with their wound. So this is all should be incorporated into our care plan that we share with our GP, and we discuss when the patients come in with an injury, or we discuss prior to managing those wounds in any way, shape or form. Next slide, thanks. So with all of our wounds, as I discussed before, we try to wet the dressings before we take them off to reduce the aerosolization. We try to modify the pH of the skin and have it slightly acidic, because we know that a slightly acidic environment is bacteriostatic. In this instance, we are using an antimicrobial wash for the first time because of the amount of exudate that was on the peri-wound skin before we start to manage this patient. We need to look at whether we're going to do ABPIs. Any wound that has a lower leg injury, we need to know what the vascularity is in the lower leg before we compose any form of plan that utilises compression. So we need to know the hierarchy of ABI results in order to determine what type of compression we're going to use. GPs get paid for ABPIs, so it's an item number that should be used appropriately to determine the etiology of the patient's wound. We need to wash all of the componentry of the ABI off in between the patients. So whenever we're using any form of initiative, we need to think, how is this piece of equipment cleaned and ready for a new patient? And at the end of the time, we need to actually take the componentry out so that we can clean it down and have it ready for the new patient, so that our routine is always knowing that when we grab the machine, it will be ready for the new patient. We're not going to be surprised that someone has not cleaned the wound. So if you've got policies in place that you know whoever uses the machine, their job is also to clean it at the end of utilisation. It's really important so that no accidents occur. Should an accident occur, it's really important that we also have practices that cover clinical governance. How can we avoid this in the future? How can we determine new protocols within our workplace that stop these accidents occurring? And we all have bad days, so accidents will always occur. We have students with us, we have a range of people coming in and interrupting us. So we always need to look at, okay, this has occurred, creating a non-blame environment, but to record it and to show in a clinical evaluation that we've actually determined steps that we can overcome the risk of it occurring again. It's very complicated clinical practice, but if we create an environment where everyone can share, look, this incident occurred, how can we prevent it happening again? It's one step towards infection prevention in the future, learning from our mistakes and preventing them from happening again. Next slide, thank you. Now, when we're looking at our patients and the wound environment, we need to be mindful of when we're going to be taking biopsies and when we're going to be looking at swabbing. Now, I would always recommend for patients that have had a wound that have been referred to you for longer than 6 weeks, that you would look at a biopsy to look at the histology and the pathology in the wound. It's really important for our practices that we look at all of our wounds and we have documentation that shows our evaluation of the wound program that we've initiated. Internationally, when you read any of the new documents around and consensus documents around the world, it's recommended that we have a plan to look at how long are we going to leave our wounds if they're unchanging. So if a wound is remaining in the inflammatory response or is remaining in the infection for longer than 4 weeks, we have to determine what etiology have we got. Is it correct? Do we need to refer this patient to another clinician, such as a dermatologist, a plastic surgeon, a vascular surgeon? Always in the back of our mind, we need to be thinking, okay, let's reevaluate using a clinical handover paradigm, sharing with the GP and other clinicians in the clinic to determine, okay, 4 weeks, at 8 weeks, at 12 weeks, is the wound progressing? Do we need to refer them on? Next slide. Now, this is one instance that we can share from our clinic. This is a gentleman whose wound was just not progressing out of the inflammatory response. And we took 3 biopsies that all came back with no lesions in situ. And after the next 4 weeks, the wound still hadn't changed. So we determined, okay, we've got the etiology that we can't alter. We've actually determined that we've done biopsies. This wound hasn't changed. Let's refer it to a plastic surgeon. Now, the plastic surgeon shaved all of this wound, and despite our 3 biopsies in this wound, found that there was a squamous cell carcinoma in situ. So always be confident in saying, look, we did the biopsies, we had nothing abnormal detected. Can you help us? And that is the job of the advanced medical clinician in supporting good clinical governance of what we are conducting in general practice. Next slide, please. Now, effective management of wound infection. This is our final stage as we come down to 20 minutes. We need to know our patients. We need to know that we can add to the care plan should we get referred other patients from other GP practices. But we need to also add to our care plans. If we've got a patient that we know all of their comorbidities and they develop a wound, for example, they need to then have another ABPI. We need to know the vascularity before we put them into compression. We need to know the contributing factors. We need to have enough space to conduct the necessary elements of wound management. We need to evaluate with proper documentation that other clinicians we're referring to can understand. It's pointless having long documentation practices that no one is wanting to read. You need to have something that people can look at and succinctly see what you've done, did it work, why are you referring them? And look at who you need to refer a patient to at any particular point in time. Next slide, thank you. Before you touch a wound, you've created the environment, you've got the clean space, you know the dirty space, you're wearing your proper PPE. You need to look at the diagnosis. Have you got the proper diagnosis? Are you treating the underlying cause? Then you look at managing the wound. Managing the wound is down the ladder of implementation for managing wounds in general practice. Without having a proper diagnosis and treating the underlying cause, you are at risk of infection by adding to the burden of too much debris in the wound base without it actually treating the cause. Too much debris, too much exudate in a poorly managed wound is going to lead to infection. And it's our job to unravel the mystery that the body is showing us with the signs and symptoms of tissue and exudate at the wound base. Now, I'm giving a topic that I could talk about for a week in 20 minutes. So please forgive me for talking very rapidly and giving a lot of information very quickly. Then finally, as we are conducting wound management at the wound, we need to be monitoring it every 4, every 8, every 12 weeks. Is the pain reducing? If the pain is still extraordinarily high, maybe we've got an autoimmune response and may need to refer the patient to a dermatologist. Is the patient experiencing pain because of lack of blood flow? Are they getting claudication at the end when they're walking? Do they sleep with their legs down at night? All of these things would concur to a plan that we need to refer them to a vascular surgeon rather than leaving them too late with dressing products that aren't simply going to work. Next slide, please. This is a wound exhibiting the symptoms of what I was telling you before. When you look at the first wound, you can see that the wound itself has debris in the wound. You can see evidence of discoloration associated with Pseudomonas. And our first step is, will we use antibiotics or not? And that's usually our last step. So the first step is to apply lignocaine, 5% UNG, to anaesthetize this wound and prepare it to actually be clinically debrided or mechanically debrided. We use the UNG, we wrap it in Glad Wrap, we use an antimicrobial, and then we wash it down. And you can see in the second wound that we have debris in that wound base. So if we had have just applied new dressing products after a simple clean, we would have had debris in the wound that is the nidus of infection. So once we clear the debris from the wound with an antimicrobial wash, we then soak the wound with an antimicrobial, because when you've actually distributed or impacted biofilm that could be 3 millimeters below the surface, and we've got planktonic microbes in the wound base, we want to then kill the planktonic organisms with an antimicrobial, and then we treat the wound itself with another antimicrobial appropriate for a high level of contamination, such as flemazine. We use this in the wound because the wound was painful and the patient was able to tolerate every 2 days aggressive cleaning, aggressive washing, and then antimicrobial, and the wound healed without any antibiotics. Next slide, please. This next slide we can see is a wound that we manage with compression rather than with antimicrobials rather than antibiotics. It is a gentleman with melanoma, heavily exudating wounds, and lymphedema, and the melanoma was in the inguinal space. So he had swelling in the lower legs. Once we utilised compression, the fluid leaking through the wounds, damaging the tissue, was reduced, and those wounds started to, they didn't heal, but they were able to be managed so that the patient could get on with what quality of life he had left. Next slide, thank you. And this is a really important slide because these are the posters that are available to all general practice nurses who join Wounds Australia, looking at how we can use our dressings for each patient when we don't use all of the dressing. So we look at patient-specific equipment that we use, keeping it contained in a Ziploc bag. Where do we cut these dressings? In our clean space. Do we cut the dressings in the patient's environment? No, we don't. We take it via a dressing pack into the clean area. We cut the dressing, we put it back into the dressing packet that the dressing came in, and then we fold it up, tape it, and then put it back into a Ziploc bag. We clean our scissors. The next slide, thank you. So we look at getting the dressing product that we're going to use in the wound. We take the dressing pack that's beside the patient on the trolley, take it to the clean space, fill that with the increments, the ingredients that we're going to use. We then fold the dressing back in place, and we know that we've not contaminated any of the dressing because all of these components are kept for the patient's own use. We do not use dressings in between patients unless they're in a clean area, and we draw them up with a syringe and take that syringe to the patient's environment. Next slide, thank you. Next slide, please.
Okay, well, I think we've come to our questions part. Thank you for that, Cheryl. That's a lot of information in a short space of time.
I'm so sorry. Yeah.
That's okay.
But there's plenty of documents to read that you can get online.
Excellent. Thanks for that, Cheryl. We have got a couple of questions that have come in previously to today's webinar. So we might just start with those. And then if there is any other questions with any of the participants that are on the call at the moment, please pop them into the Q&A box and we will jump to those. We'll also respond to any questions we don't get to when we send out the recording post-workshop. So the first one that I have, and interestingly, Gemma's already made a comment in the chat box there around coming from a hospital setting previously. I'm surprised that my GP clinic used sterile dressings and wound care material for multiple patients. For example, Chlorhex is opened for use, left over stored and used for other patients, or large gelinite packets opened and accessed in a sterile manner, and then leftovers left in the packet for next required use. One of the questions that we have had come in previously is, can you keep sterile dressings to be used on next same patients at another appointment?
Thank you very much. So the practices of using the same dressing on different patients has well and truly passed. We are no longer able to share dressings in between patients. Solutions are different. If you've got a clean area that you're not taking the solution from the clean area to the patient environment, you're drawing it up in a solution, in a syringe, and taking the syringe filled with your antimicrobial solution to the wound base, to the wound area, you can use it from different patients. But you've got to be mindful, once you open a large bottle of solution, you've got to write on the bottle, when was it opened? And you've got to read the manufacturer's instructions, because we know that some cleaning solutions are contaminated by Pseudomonas after 24 to 48 hours. So we really need to know if the manufacturer recommends an open dressing, an open solution being just with a screw cap on and being safe for use in a week, in 2 weeks, 4 weeks, or 6 weeks. So we need to be very mindful of how they're to be used. And we need to always, if we're using a dressing for the same patient, that we create a clean environment for cutting that wound. We create a clean environment to put it back into the receptacle it came out of without contaminating it. And we need to put it into a Ziploc bag so that that is labelled with the patient's name and used only for that patient.
Excellent. Thanks for that, Cheryl. The next question is, can dressings and gauze be sterilised?
No. In general, we in Australia are covered by the TGA recommendations. So we need to follow the guidelines very clearly of how we use dressing products and when we can reuse the dressing products for each patient. Now, guidelines are developed for us to follow and be safe within. If there are no guidelines available for the innovative use of sterilisation of products, that is for a reason. It is not to be done. So we never re-sterilise dressing products because it changes the ingredients in the dressing product and can also interfere with the absorbency of the dressing product, but the authenticity of the product as it was stimulated in the first place. A lot of products are sterilised via chemicals rather than through moist sterilisation. So you need to have a lot of information at your beck and call if you're going to try those sorts of principles.
Excellent, great answer. Thank you for that. Now, we do know that we are operating in Victoria. We are in peak risk rating at the moment with COVID. What PPE should I be wearing to provide wound care or assist in a procedure?
Wound care historically has always been up to the clinician to use, and I think clinicians have always been a little bit laissez-faire with the organisms that are around. Now, when I work in community health, when I work in general practice, I always think of an infection specialist saying that of all the microbials that are out there, we only know about 25%. So 75% are yet to be diagnosed. So it's really important that we try to wear full PPE. So I use a mask with a shield, I use goggles, and I use the plastic gown. And I'm telling you, I am mindful of what solutions need to be left in contact with the wound in order to kill the organisms when I'm sitting with a plastic gown on, because it's extraordinarily hot. And this is particularly relevant if you're looking after homeless people in parks, for example, and you don't have air conditioning to cool you down. Burn surgeons use cooling agents underneath the gowns. So we need to actually be mindful, if we're going to be using PPE, of creating an environment whereby we can wear the PPE without passing out. So it's really important for us as clinicians to think about what PPE are we going to use? Are we going to use the plastic aprons? Do we need to use the full sleeved gowns? This is for you to determine, are your GPs going to in fact buy all of this equipment? What types of wounds are you going to use? And if you've got a contaminated wound, or if you've got a patient that's immunocompromised, and I've spoken about the need to think about what's going on with each patient before we start talking about the dressing products, and thinking what environment do we need to create for them, and what environment do we need to protect ourselves and our loved ones going when we go home. And one of the first things we need to look at is banishing fingernail polish in the workplace, removing our rings and our watches on our hands before we wash up, because these are great for actually migrating organisms between patients and indeed from the workplace into our homes. So we need to be mindful of all of that. And we need to be mindful and cognizant that rings on our fingers can make minute tears in the gloves, which places a great risk of contamination.
Excellent, lovely answer.
I could talk for about 3 hours on that alone.
And that's what we love about you. So an interesting one, and certainly Lisa and I have spent a lot of time in the last few months talking around what activities can and can't be performed outside as part of the Infection Prevention Helpline. Can we perform wound care outside?
Look, this is a really important indictment of us in society, isn't it? That we have homeless patients out there that have no homes. And really, we need to actually create an environment whereby we can manage our patients that are homeless in the community. And there have been wonderful operations. I know the ones in Western Australia and in Brisbane of agencies working with the homeless in order to do wound management there. And the same environment is created. We need to wash whatever dressing table we're going to use for the wound with our Clinell wipes or antimicrobial wipes. We need to create a clean environment with our clean products, syringing and doing that. We can do all that we do in a home that we can do in an open air environment. And I feel more comfortable, in fact, in this COVID environment, having cross ventilation, looking after COVID positive patients in an open environment, whilst protecting the patient's own privacy. And I choose sometimes when I'm in full plastic gowns to actually ask the patient if they mind me conducting their wound management on the verandas because of the wind and the heat in the houses. Because they're all old, they love a warm house. Some people have heaters going right through summer. So that and plastic gear is very detrimental to an old wound nurse, let me tell you.
Excellent, thank you. So hopefully that answered that question for people. I think we've got time for maybe 2 more. It's 12:20. So the first one I'm going to ask is, some dressings are very expensive. Can we charge the patient because the practice won't pay for them?
Definitely. This is a really important question as well, because having been reading the recommendations of the new task force that was developed for wound management, they're talking about overriding that old law of the fact that if you were bulk billing the patients, you couldn't charge for the dressings. I don't know at this stage whether that has actually been rescinded yet. So it's really important for us in general practice to be mindful of these requirements through law. I don't think that there's anything that is wrong with getting the patient to purchase their dressings and charging a gap at the present time to conduct wound management practices. The things that we do are generally underfunded, particularly now. The items of debridement that we used to be able to do in general practice have been taken from general practice and given to surgeons in the hospitals. So we know there are not enough surgeons and not enough operating hours for patients requiring debridement to go to surgeons to be billed for debridement. So we need to actually think about, okay, are we going to charge a gap for debridement and then get the patients to purchase their dressing products online? Some patients get a great discount online. They're very frugal and they're up to the task. And they feel part of the team as you start to educate them why we're using expensive products. And it's even more important that if you're buying an expensive product, we're going to use it multiple times. Thank goodness for the guidelines that Wounds Australia have brought out to show that we can cut the dressings and reuse them again in between our just one patient.
Excellent. And I think that's a really important point is,
absolutely.
Yes, it is about single patient. And it is about storing those dressings correctly if we are going to engage our patient in purchasing those dressings. I'm going to throw one last one at you. So we've got a couple of minutes before I'll hand back to Lisa. And this one is one that Catherine's actually just put in the chat. And she's asking what our opinions are on lanyards.
Oh, good question. Well, if you're in full PPE, lanyards aren't going to be a problem. But remember the old days in the hospital with the doctors and the ties. Ties were outlawed, and sleeves that went below the elbow were outlawed for clinical practice. So lanyards belong in that group as well, unless you're very mindful and cleaning it, sterilising that instead of dressing products, I believe would be important, but they don't belong in a clinical environment any more than wristwatches, rings, false fingernails and nail polish.
Excellent. Thank you for that, Cheryl. I'm going to leave it there because we are just about out of time. So I'm going to hand back to Lisa just to close off for us.
Thank you very much.
Thank you, Cheryl. Thank you, Sarah. Okay, so thank you for joining us today, and thank you for the support of the PHNs. Can you please complete the survey that will get sent through to you? This will provide us with feedback that we can use to improve our service. We'll email a copy of today's webinar and the recording with the certificate of attendance. And we'll have our next webinar on November the 18th. So keep an eye out for that one. But I think that's all that we need for today. Thank you.
Thanks, everyone.